So it's my pleasure then to introduce Imran Chaudry, who is another member of the neurointerventional group at MUSC, who's going to speak about stroke.
Thank you. Thank you, Claudio. All right, so we're going to talk a little bit about the other side. Alex did a great job on the hemorrhagic side of stroke. We're going to touch about the ischemic side. So where are we now and where are we going? All right. So we started with first-generation thrombectomy devices. First-generation devices were the Mercy thrombectomy devices, essentially a fancy corkscrew, which was designed to engage the clot and remove it. Had significant limitations. The biggest one was traction on the vessels. You would actually be pulling the vessels down, and there was big concern for avulsing some of the perforators as well as denuding the endothelium. Additionally, we were only able to achieve marginal revascularization rates with these devices. We can see here the device deployed in the MCA. While pulling, we can actually see the displacement from the original position of the MCA. When we would do patients awake, they really did not like this. They did not tolerate the procedure very well. They'd sit up complaining and screaming. So we kind of stopped doing that. Second generation devices, we moved on to fancy shop vacs. This is essentially a thrombectomy aspiration system. You can see the plunger there that's used to separate the clot, and the catheter is set to essentially a vacuum cleaner and suck out the clot. And so a little bit of work and the clot goes away. But again, there was limitation with this device as well. Most notably, we had a relatively higher incidence of downstream emboli and only moderate revascularization rates. Just an example of what we were able to do with this. Here is a patient with a left middle cerebral artery occlusion. We're able to take the catheter up there. And after a little bit of work, you can see that we've got downstream emboli into the M2 division. And again, a little bit more work, we're able to get complete revascularization. But with that device, we would always commonly find that we were chasing clot downstream. We moved on to current generation mechanical thrombectomy or stent retrievers, and we all thought that this was going to be kind of the holy grail for thrombectomy. And the idea was you deploy this device across the clot, you get instant reperfusion of the affected territory, and you're able to also remove the clot with this device. We actually did things a little bit differently. We accompanied this device with one of those large bore aspiration catheters, did a modified technique called the Slumbro, where we put the large bore catheter at the interface of the clot, use the stent retriever to achieve reperfusion, and then pull that stent retriever back into the catheter for thrombectomy. But again, one of the biggest problems with this system was ENT, or downstream emboli or fragmentation. Here you can kind of see that there's a little clot sitting there on the stent retriever. As it comes across the bifurcation point, you can see it go flying downstream. So while you may have recanalized the affected vessel, you've now caused emboli into a new territory that you have to go chase. Well, this is a very busy slide. What we're trying to show here is that over time we've gotten significantly better with our recanalization. A lot of the earlier studies used the Tiki reperfusion scale, and a lot of those earlier studies used 2A or better as adequate reperfusion, whereas a lot of the newer studies are looking at 2B and better. And that is significant because 2A and 2B is differentiated by about 50% of reperfusion. And so while we can see that we've gotten significantly better recanalization rates from when we originally started, we're up to 90-95% complete recanalization, there is some disparity with outcomes. We can see that while we believe that recanalization is very important and portends the best outcome for these patients, we're still only able to achieve 40 to 50% functional outcome rates with these procedures. So how do we improve from this? Well, there's two ways to do this. One is improve our devices, get better rates of recanalization, and also better patient selection. So one of the ways to do that is, with the devices, we're thinking of revising the Tiki scale to include a category of about 2C, which represents near complete recanalization with very small distal emboli. And we think that not only should thrombectomy be performed, but it should be a good quality thrombectomy, i.e. meaning removing the entire clot if possible. And this is kind of what we're talking about with those stent retrievers or with the other devices. We've never removed the clot, so it had to go downstream and would have to be somewhere causing a little distal microemboli. With some newer techniques, we're actually able to remove the clot as a whole, which I think represents a better quality thrombectomy. So obviously we can revascularize these patients fairly well, but we do need to work on the speed and the quality of the thrombectomy. We've kind of, and a lot of this is due to, or we need to do this to obviate this ENT phenomenon. And so we're able to do this. We've developed a technique called the ADAPT technique, which essentially takes those large bore catheters out to the clot interface. We use those large catheters to engage the clot, set that catheter to aspiration, either using an aspiration device or a 20 cc syringe, and then remove that clot as one big piece. And that's kind of what we're talking about. We're able to take these patients that have, in this patient here, a basilar occlusion, use that ADAPT technique and remove that clot as one big piece. And so we're able to do this fairly quickly and efficiently. We're able to, when we first started doing these cases, thrombectomy cases would take somewhere between 2 to 3 hours when we first started. We're able to get these complete recanalizations now in 10 to 15 minutes. Just another example of a middle cerebral artery M3 occlusion, 45 minutes to complete recanalization. Another example of an MCA bifurcation occlusion, again, 7 minutes to complete recanalization. We're so excited about this technique. We told some of our friends across the country. They started doing it. This is one of our colleagues in Chattanooga. 11 minutes, pulled out a 5 centimeter clot on his first attempt. And just another example. One of the greatest things about this is because our procedures have gotten to be so much quicker, we're able to do these patients under conscious sedation instead of general anesthesia. The benefit of that is we're able to see these patients actually get better on the table. So, procedure is fast. Kind of what we were talking about earlier, looking at our time from when we first started this with the original first generation, second generation devices, procedure times would take on average about 85 minutes. With this new technique, we're able to do these cases from start to finish in under 40 minutes on average. It's also safe and efficacious. We're able to achieve complete recanalization in about 78% of the patients using ADAPT alone. Use of adjunctive devices increases that recanalization rate to about 95%. We're able to achieve high rates of functional outcome in 90 days. Approximately 50% of the patients in this series all had good functional outcomes and are independent at home. It is also very cost effective to do this technique. When we looked at our costs with those first, second generation devices, our average cost was about $11,000 per procedure. With the use of the stent retrievers, those stents are actually fairly expensive. They added cost, quite a considerable amount of cost to the procedure, and our cost went up to about $16,000. When we take all that stuff away and we're using just that simple ADAPT technique, our costs come down about $8,000. It saves the hospital about $20,000 per procedure overall. We include direct and indirect costs. If we're doing 100 cases a year, that's almost a $2 million savings to the hospital. And again, a lot of this is achievable because these new generation large bore catheters, we're able to do these cases under conscious sedation because it is now painless. There's none of the displacement of the vessels. These catheters track much easier. And so there is considerable significance to the fact that we've moved away from general anesthesia and just using conscious sedation. Our critical care group looked at the implications of using general anesthesia, and what we found was that approximately 26% of all patients that underwent a thrombectomy with general anesthesia had significant ICU complications, which lengthened their length of stay, and also had a relationship with poor outcomes. Those patients that did have ICU complications, only about 20% of those patients achieved a functional outcome, whereas those patients that did not have an ICU complication, almost 50% of those patients achieved a functional outcome. And so this is what's really important. We're able to do these cases awake. So you have a patient who presents with a right MCA syndrome, they're paraplegic on the left side. At the end of the procedure, you've recanalized them. They're actually able to move their arm on the table, which tells you that you've done a functional thrombectomy. So just a quick example of what we're talking about. An 86-year-old gentleman who presents with left facial droop, hemiparesis, dysarthria, stroke scale of 12, lasting normal 11 o'clock the night before. He's outside the time window for IVTPA. At the Lotta Center, he's also outside the time window for thrombectomy. He's 7 to 8 hours out from his last known normal presentation. His CT scan looks pretty good. You can see the hyperdense MCA sign there on the right side. The parenchyma looks relatively preserved. We use CT perfusion to determine what patients are still candidates outside that time window. What we see here is in that CBV, there's a small core infarct in the right basal ganglia. The mean transit time tells us what areas of tissue is at risk. The red area is all that tissue that is potentially salvageable. If you do not do a thrombectomy, that tissue could potentially die. But using this kind of information allows us to determine which patients are still candidates for thrombectomy. At angio, he was found to have a complete carotid occlusion, as well as a second tandem occlusion involving the internal carotid, which extended to the middle cerebral artery. A little quick angioplasty here at the bifurcation. We're able to stent, recanalize, go back through it, get our catheters up to the internal carotid. We can still see that there's a complete occlusion there. A little bit of work getting these new large bore catheters all the way up there. These catheters are about 0.55, 0.54, so they're about a 4 French, 5 French catheter that we're able to get up into the middle cerebral artery relatively quickly. You can see here, the catheter navigates pretty quickly around the carotid siphon. A little bit of work, about 5 minutes of work, and we're able to pull about 5 centimeters of clot from that internal carotid artery in the middle cerebral artery. He ended up walking out about 4 days later, completely normal, with just very, very mild dysarthria. So not only are we able to achieve better recanalization rates, and we're able to do it quickly, but we do need better methods of selecting patients. We're selecting patients based on perfusion, but what we're really looking for are leptomeningeal collaterals, which are God's way of helping us out when we have these occlusions. We can see here this patient with an MCA occlusion. We can see that the ACA fills relatively robustly, and there are some collaterals that come along the side to help reperfuse that middle cerebral artery distribution. And so it's kind of making things work, right? So this guy who's married, he's missing something, but he's making his marriage work somehow. All right, so we're able to do this by looking at perfusion. We can do this based on MR and CT perfusion. We're essentially looking at what we call the 4 Ps, the pipes, the perfusion, the parenchyma, and essentially the penumbra. We're able to do this, again, with either MR or CT. A lot of this depends on what your institution does better. We do a lot of CT perfusion, and again, we're looking to see where the pipes show. We can see the MCA occlusion, the perfusion, which tells us what tissue is salvageable. We can also see what tissue is already dead, and the penumbra. And the penumbra is really what matters. That the larger that mismatch, the better the chance that the patient will do better. We can kind of skip this in the interest of time, but basically what we're looking at is just collateral pathways. Another way of looking at it is a traffic jam. We all know what happens when the Ravenel Bridge closes down, right? It takes a long time for us to get there. And when that closes down, our mean transit time goes up. But if we have a lot of compensatory side routes, right? So if we have to go take the Don Holt Bridge, make our way around, it takes a little bit of time, but eventually we all get there. And that's MTT and CBV, which are measures of those collateral routes. The net variable effect is CBF, and putting that all together allows us to determine what patients are good candidates. And so we do this based on CT perfusion. Basically, we've looked at this series of how these patients did, taking out time altogether and just utilizing perfusion. Over 140 cases utilizing those first and second generation devices. We're treating big, bad, ugly strokes, stroke scales of 16 and bigger. Our average time to treat was 11 hours, which is well outside the time window for most other centers. We're able to achieve really good rates of recanalization, about 87%. Our outcomes are on par with almost every other study that's been performed. We're able to achieve functional outcomes, independence for our patients, ranking 2 or better in 38%, and 3 or better, which is still a functional outcome. They're at home but may need a little assistance, and 50% of patients are better. When we looked at the time window, whether there was a difference in those patients that we treated earlier versus late, there was absolutely no difference, and maybe a slight trend towards better outcomes in those patients that we treated after 7 hours. That's probably because we were selecting them a little bit more carefully. So in conclusion, we need to realize that there are device and operator specific outcomes, and as well as better patient selection outcomes that were necessary. Thank you.